Well, hello and welcome to another edition of OCD Town Hall. As always, we like to give you a couple minutes to get in and get seated and relaxed, get everybody. So with that, if you're already here and viewing, please say hello. Let us know where you're viewing from, and we'll get started in the next 60 to 90 seconds. And I see Jessica was here early, so hello, Jessica. There's Beth. Hi, Beth. I hope you're doing well. If you're just joining us, we'll get started in the next 60 seconds or so, just letting people get a chance to get in the door. So please say hi. We always like to hear from you. And if you want to let us know where you're from or your favorite flavor cookie. I don't know that we've done cookie. We've done ice cream, dessert, maybe cookie. Hi, Tracy. And Jessica is Midwest, USA. I appreciate the Midwest. Hello, Deirdre. Hi, Don in DC. It was great talking to you on Tuesday as well. You had some great questions, so thanks for joining in the conversation. Watching from British Columbia, Canada. Welcome, Canada. It's beautiful up there. And we'll give it just 30 more seconds. We've got an amazing town hall for you this evening with a really fantastic panel. So get your questions ready. We'll be talking as usual for a few minutes and then jump into questions. Again, if you're just joining us, let us know you're here. Say hello. Let us know where you're from. Nobody's told me yet what their favorite cookie is. I'm dying to know. I get confused because I like white chocolate chip, but then they throw in macadamia nuts and sometimes it's the same thing. And then I stress about it. And then my OCD attaches to it and wonders if I really had macadamia or white chocolate chip, and it can get quite stressful. No, it doesn't seem that stressful.
I don't discriminate with cookies. All are welcome.
All cookies are welcome. Shortbread. Interesting. I like shortbread sometimes. Dr. Goodman, what's your favorite cookie?
Chocolate chip.
How about Alexandra?
Chocolate chip.
Yeah. That's the can't go wrong. When you're dying for a cookie, that is the way to go. All right, with that, let's get started. Welcome. This town hall is on OCD and depression. My name is Ethan Smith. I'm the national advocate for the International OCD Foundation, which simply means I have OCD and I won't stop talking about it at least twice a week. Hi, Michigan. Welcome. They have cookies and cream cookie. There's a cookies and cream cookie? Wow. Is that like just an Oreo cookie, or is there a flavor of cookie? That's kind of meta, no? All right. Anyway, let's jump into some quick opening housekeeping so we can dive into what we're all here for. This town hall is intended to serve as educational content and is not intended to replace therapy. For treatment-related questions, please be sure to work with your local provider or contact the local clinician. The International OCD Foundation is not a crisis hotline and should not be used if you're in stress or feel unsafe. If you're in a crisis or you're ever feeling suicidal or unsafe, please go to your local emergency room, call 911, or call the suicide prevention hotline at 800-273-8255. As always, we want to be as respectful and kind to others as we can and create a safe space as possible. We always have to mention that this is public. It is on Facebook and YouTube and Twitch and various other social platforms. So while we can't give you total privacy, always keep that in mind. But with that, we are all here to support one another and have as open and honest a conversation as possible. So please be kind and respect everyone's comments, thoughts, and wishes. With that, hey, Eric Broach in Houston. What's up? You have a neighbor, Dr. Goodman. Eric's in Houston. Eric is also the most winning trivia player of our IOCDF trivia once a month. He is currently unbeatable when he plays. With that in mind, and hi, Mary in Milton, Georgia. Let's get started and get to know our panelists a little bit, and then we'll dive right in. So first, I'd like to introduce Alexandra. She currently is a stay-at-home mom to her beautiful 2.5-year-old son, who we had the pleasure of hearing right before the live stream. She has been living with OCD since the age of 6 and is passionate about breaking the stigma around mental illness. Prior to being a pro boo-boo healer, which is literally my favorite thing in any bio I've ever read, Alexandra graduated from Kennesaw State University with a Bachelor's of Science in Psychology. She went on to turn her passion for both mental health and women's rights into a career as a domestic violence victim advocate, specializing in working with Latinx and undocumented population, which is incredible. When she's not fighting for social justice, Alexandra loves spending time with her husband, son, and rescue pup. She is also an avid reader, loves video games and hiking. Alexandra, thanks so much for joining.
Thank you so much for having me. It's an honor.
Well, it's an honor for us. Next, we have D. Ross Franklin. D. Ross Franklin is the director at NBI Ranch and specializes in the treatment of OCD, feeding and eating disorders, anxiety disorders, and related conditions. She's a certified provider of the Unified Protocol and emotional focused family therapy and has received intensive training to provide cognitive processing therapy. So, Dee, thank you so much for joining us.
Thanks for having me.
Excited to have you here. And finally, Dr. Wayne Goodman is a professor and chair of the Menninger Department of Psychiatry and Behavioral Sciences at Baylor College of Medicine, specializing in OCD and obsessive compulsive disorder and deep brain stimulation for intractable psychiatric illnesses. He's the principal developer of the Yale Brown Obsessive Compulsive Scale, the Y-Box, the gold standard for assessing OCD, and co-founder of the International OCD Foundation. So it's always special to have him on. His major advocacy group for patients with OCD. Prior to joining Baylor, he held senior administrative positions at Mount Sinai Hospital in New York, NIMH, in the University of Florida. He graduated from Columbia with a degree in electrical engineering, received a medical degree from Boston University, completed his internship, residency, and research fellow at Yale School of Medicine, where he remained on faculty for 7 years. I promise so much over Dr. Goodman. He has received numerous awards, published over 300 peer-reviewed papers, has a long-standing record of extramural research funding, and is currently a principal investigator on 3 grants from NIH's BRAIN initiative, including one on developing adaptive DBS for OCD. Dr. Goodman, always a sincere pleasure and privilege to have you.
Thank you for having me back, Ethan.
Absolutely. All right. So thank you all for joining. As always, if you have questions, please feel free to load them in the comment thread. We'll get to them in the next 30 or 45 minutes. And we do go in order unless there's something pressing that relates to our conversation, but we try to get to everyone's questions. So tonight's conversation is on OCD and depression. Dr. Goodman, I'll turn to you at first. How common is the co-occurrence of OCD and depression?
How did I know you were going to ask me that? Yeah, so I should have been better prepared, right? So it's hard to say. In my own experience, I'd say it's probably about 50% of the patients that I see. I think that it depends on really how you define depression. If you're talking, I think most people that have had OCD for a long time and where it's impacted their lives, they have some symptoms of depression. But if we're talking about major depression, which, an additional diagnosis of depression, it's probably more like 25% of patients with OCD. And I think it's more common the more severe the OCD is and the longer the duration of OCD, so that there's just kind of the wear and tear of having OCD. It's not surprising, that you would develop depression. The same way if you had any other chronic medical illness over time, if it's impairing your functioning, your livelihood, your ability to enjoy time with friends and family, it's not surprising that you're going to start to develop symptoms of depression.
How do you tweeze out whether depression is a primary or secondary diagnosis to OCD?
Yeah, so in most of the cases, it's secondary, meaning and the first way you determine that is which came first. So if you have a history of somebody who had OCD since they were young, or they've had OCD for 2 years and then developed depression, and sometimes the patient themselves will tell you that they, say, do you think it's the OCD that's causing depression? Or if the OCD was gone, how would you feel? That's probably the best question. And they say, I won't be depressed anymore because I can live a normal life. I wouldn't have the burden of intrusive thoughts and having to perform all these rituals. So I think it's been a lot of times the patient, him or herself, knows the answer, but it's sometimes which came first. And then in the end, it becomes a clinical determination.
And Alexandra, I'm going to turn to you in 1 second. Dee, this may seem like a silly question, but you run a residential program. Of the individuals that check into the program on a regular basis, what percentage would you say are depressed?
I am going to have to agree with Dr. Goodman on this one. I would say around 50% of our patients probably have an actual diagnosis on their charts. But by the same token, I think almost everybody comes into treatment with subclinical depression and really struggling, as we all understand, and OCD, anxiety-related disorders, really doesn't impact the person in one domain of their life. It's every aspect of life. But when a person walks through the doors of a treatment program, life isn't going so well. And so what comes along with a lot of that is, really significant levels of hopelessness, sadness, relationships destroyed. And so it's kind of hard anecdotally to come into treatment without at least some subclinical form of depression.
Can you quickly differentiate between subclinical and clinical?
Absolutely. The term subclinical is just a way of referring to someone who meets many of the diagnostic criteria for depression, but is not a full hit on all of the criteria. So we're kind of, if you think about a checkbox, if you had 5 items to check, maybe someone who's subclinical has 3 or 4 of those.
Thank you, Dee.
Yeah.
So Alexandra, thank you so much for, and Kathleen just put, can PTSD cause OCD? We can maybe touch on that. And Tracy, I see your question, and I'll actually jump on that pretty early because I think that's a great question to maybe start off. But first, Alexandra, thank you so much for joining us, for sharing your story, and just being vulnerable and open. Can you talk a little bit about your own experience with OCD and depression?
Yeah, sure. So I have had OCD since, honestly, since I can remember. But the medical papers go back to about 6 years old. So I've had, I think, a pretty severe case of OCD. I have a lot of different themes and overlapping symptoms, and my themes overlap. And so there have been times in my life where I think the thoughts and the interference with my life have been way too much. And that has caused me to have a lot of depression. I was diagnosed with major depression later on in my life. I was first diagnosed with major depression with psychotic features before OCD, but I think that's because of my OCD, because of the thoughts I was having. And so later on, it was moved down to just major depression.
What in your journey? Well, first of all, what's your take on all of those various diagnoses, and what do you feel like the lay of the land looks like in your own work? I mean, I was diagnosed as psychotic and it was OCD. It's not fun to get a diagnosis in that range because so many people just don't understand, especially in acute facilities or in acute situations, things like that. In your mind, were you really struggling with OCD and depression was sort of, came with that?
Yeah, I really was. I had just moved out of my parents' house and I was in college, and I think it was the perfect storm of a situation for OCD to really come out. I was starting to struggle in school and I couldn't figure out why. I was starting to lose my sense of self. I really wasn't sure what I was doing. And because I couldn't access what my values were and who I was falling deeper and deeper into kind of what I call the death spiral of, OCD and depression, where they just kept playing off each other. And the more depressed I got, the more these intrusive thoughts felt like they were real. And I think looking at it objectively, of course, someone would think I was just incredibly depressed, because I was so depressed because I could not figure out what was going on in my head. I knew that something was wrong, but there was no way for me to articulate it.
Thank you, Alexandra. Dee, why is it so important to talk about OCD and depression?
Yeah, so there you picked up on the cue, just like you said you would. I do have some thoughts on this. We were just talking about this today at a staff meeting, and just thinking about thoughts in our heads. And in a manner of speaking, isn't thinking a thought in your head or a voice in your head? Our own thoughts can sound like that. And I was nodding, Alexandra, because when you were talking, I was thinking back to how many times we've received patients coming into our facility that have maybe been stabilized in the hospital or being referred from the outpatient community, reporting thoughts, commands, voices in their head. And even coming into our facility with various psychotic diagnoses. And what we find time and time again is that there's no thought disorder on board, right? It's part of the severe and unremitting symptoms of OCD.
Dee and Dr. Goodman, I'll turn to you one second. Dee and Alexandra, maybe you all can relate to this. I found very quickly as I was in those, well, let me rephrase that. As I got into treatment and became better educated about OCD, I realized that because I didn't have a clear understanding of OCD, the way I described my symptoms presented as psychotic, because I wouldn't say, I would say my OCD is telling me. And if
Right.
a psychiatrist is in a hospital, doesn't have a lot of OCD insight, it's like, oh, you hear voices. It's like, no, but I mean, it's telling you to do these things. And as long as I say things like it's telling me versus I'm
Right.
having thoughts that, and they feel really intense and powerful. But because we don't come to the table completely educated about OCD, therein lies the pitfall. I don't know, Dr. Goodman, if you have thoughts on that.
Oh, no, I completely agree. You know, that's an important distinction. So if somebody says something like, it's telling me that I have to do this, I say, well, is that your own mind telling you, or is it a voice from space? And they say, well, I know it's my own mind, but it's as if it's got a mind of its own. And that's true for OCD. Although you recognize it's part of yourself, it has its own agenda. And its own agenda is generally to make you unhappy. It's the fine things that are going to interfere with your ability to derive pleasure from life. But it can, and you're right, in inexperienced hands, and a clinician hearing that it's telling me what to do, or I hear this voice, it's really not a voice. I mean, it's no more a voice than what Dee was saying, is that we have our own thoughts. It's kind of the voice in our head. It's just from a part of our brain that is kind of been corrupted by the OCD. And it knows, and it knows how you think, and knows what's important to you, what you fear the most. So it's a very, very scary illness.
Has a habit of jumping onto those things that you care about the most. You
Yes.
could almost predict it. I'm not sure, Ethan and Alexandra, if you guys can speak to this, but you could almost predict when something matters, when something's important, that part of the brain is going to latch onto that thing and play tricks with you.
Yeah, that's been my experience.
Go ahead, Alexandra.
Yeah, no, that's definitely been my experience. As I become more versed in OCD and more kind of educated in my journey with it and learn more about how it works, I have noticed that I can predict. If I really start caring about something like a piece of art I'm making or this panel discussion, the OCD becomes very loud. I can almost predict if I have something coming up the next day that I really am excited about or care about, that night it's going to be hard because my intrusive thoughts are going to lead me down that path of ruminating and, just jumping right on whatever it is I'm caring about the most at that moment. And it's frustrating because you feel like you have no control. It's coming, and that anticipation almost makes it worse.
Absolutely. And to all of those viewing, if you start to have any questions or thoughts, as always, please feel free to put them in the comment thread, and we'll get to them probably in the next 20 minutes. With that, I know I can definitely relate to that, Alexandra, and I don't want to. I like to typically take ideas from the smartest people I know, and then claim they're mine. I've done that multiple times, but alas, Dr. Croppinger, who works at OCDI McLean, said it best, which I love. And we were doing a panel, and he talked about, if you're severely depressed with OCD and you're having trouble finding what you love or your values because you just don't care about anything, track the OCD backwards, see where the OCD is attacking and follow that rope back to, and that most likely always leads to the value or the thing that you love the most. And I really liked that, working it backwards and sort of using OCD against itself to find what's meaningful to you. Dr. Goodman, I mean, you're at an advantage because you obviously have a deep understanding of depression and OCD. I think it's important to talk about here, what is a common pitfall for someone that is engaging a psychiatrist, which for many times is a first line when they're struggling with depression or OCD, that most psychiatrists do when they're prescribing a medication. So for instance, I went to a psychiatrist for 15 years who treated my OCD with medication and hoping the depression, but never dove any further, never knew to refer me to ERP or anything like that. What role do you see as medication, and then where would you defer out?
Well, one thought I have is that I try to teach our trainees, our learners, that if somebody presents with depression or an anxiety disorder, make sure you at least ask a few probing questions about OCD. And the reason that's important is, as we all know, people with OCD have insight into their symptoms. I mean, it varies to some degree, but a critical part of the diagnosis, they recognize, at least in moments when they're not as and the symptoms aren't intense, that it is a product of their own mind, that at times it is excessive and that there's something wrong. And then they worry that about the stigma of it. And they're afraid that other people are going to think that they've lost their mind, that they are psychotic. And so they may present with symptoms of depression and not reveal the other hidden thoughts, the intrusive thoughts, the rituals that they know may appear bizarre to other people and certainly excessive. So it's really incumbent upon the clinician to make sure that in cases, because comorbid depression is so common in OCD, to make sure you ask a few probing questions to see whether they behind the scenes, behind the depression, you find that the underlying problem is OCD.
Thank you, Dr. Goodman. Alexandra, do you have additional thoughts?
Yeah, I mean, I think that's absolutely right. I know in my experience being hospitalized, unfortunately, they did not ask any questions about OCD. And so what they did ask me was, you know, are you hearing voices and things like that? And I was like, well, yeah, but it's not like what you think. And, you know, me not knowing that I had OCD, I could not explain that I'm having intrusive thoughts. And so that kind of leads you down that wrong path if you're not well-versed in OCD and then asking those questions. I think that's super important.
It's super frustrating too, because then the antithesis, I went completely dysregulated and a disaster with a diagnosis of OCD, which I got at the age of 14, but didn't find the proper treatment until 31. So I went with a diagnosis of OCD to an acute psychiatric facility, and they were like, no, this is not OCD. This is definitely a psychotic break or something else. And it was like, you know, to me, that was even more disheartening, because I'm like, what do you mean it's not OCD? I thought it's been OCD this whole time. I'm super confused. So, you know, regardless, there's education here that needs to happen. You're dealing with individuals with any type of mental illness, like why can't we better educate OCD? With that, Dee, what has your experience been with sort of depression getting in the way of treating OCD?
Definitely. I think that feelings of sadness in general, and including depression, interfere with the first entry level to treating OCD, which, as we all know, is behavioral activation. It's always the place where we want to begin and get somebody moving, physically moving, but also, you know, metaphorically in their treatment moving. And when you're depressed, it's hard to do just that. So part of what I've found over the years to be the most successful way to combat this entry point is to focus on the small things, to focus on the basics. So we're talking ADLs. We're talking showering, brushing teeth, changing clothes. I have this saying with my patients. I always say to them, when you get up in the morning, make your bed. If that's the only thing you do, make your bed, because a made bed is more difficult to get into than an unmade bed. So I think that to be kind of more direct to your question, Ethan, depression interferes right from the get-go. It interferes when you're trying to discover what a person's values might be. Because they might not be able to see past the hopelessness that they're experiencing. It interferes with their ability to function at a very basic level. It interferes with their mood. As you know, mood and OCD treatment is so important, because as the treatment starts to progress, we really start to see changes in mood. So when we're finding it difficult to target that depression in the early days, it really impacts the quality of the treatment overall.
So with that, Tracy at 7:10 p.m. asked, should you treat depression first or OCD?
Well, you know what? I think that that's a great question, and you should treat them concurrently. And I think in many ways, a good OCD clinician is probably already using CBT and ERP, we hope. And those treatments are designed to target both transdiagnostically, correct? So I think the answer is maybe not to tease them apart and to treat them together.
Thank you, Dee. Alexandra, anything to add?
I mean, no, I agree with everything that
you're not required to add anything.
No, I agree with everything she said. It's completely on point. I think depression definitely gets in the way of OCD, and the same tools that we have in our tool belt for OCD can be used with, you know, depression. And I would even take it a step farther and say that acceptance and commitment therapy can help as well.
Mm-hmm. Definitely.
Go ahead, Dr. Goodman.
Yeah, so let me add one thing, and that's about the role of medications. And and I'm not saying that you have to prescribe antidepressants, particularly SSRIs, to everybody who has OCD and depression. But if they have significant depression and you've tried some of the tools that Dee talked about, and they're not making progress, they're still not being motivated, they don't have the energy to comply with the treatment, there should be some consideration, if it's available to you, for use of the SSRI. So, and the SSRIs, and that's not the only medications, but it's kind of the mainstay of our medications for OCD. They are also antidepressants. So what you would hope is that they will not only treat the OCD, but they'll treat the concomitant, the coexisting depression. And there's no reason to believe that the SSRIs or clomipramine will interfere with the efficacy of the behavioral therapy. So I just think it needs to be a consideration part of the equation. And then in the end, it becomes a decision between the prescriber and the clinician and the patient. And obviously we have to listen to the patient in terms of whether they're receptive to the idea of medication or they want to try without it.
Thank you for bringing that up, Dr. Goodman. I mean, in fact, Dee, did you have another thought to that?
I do. Time and time again, studies looking at this have shown that medication and behavioral therapy alone can get somebody so far and no further. But when you really combine them, we know that our patients can get much further when we are working together, the medication compliance and the therapies. And I would go one step further to say that in our setting, or in any day or residential setting, when we are struggling to get traction on those basic elements of behavioral activation, we are absolutely looking to psychiatry to help us with the meds, because sometimes that's the only way to get things going along.
Absolutely. I'm happy to speak to my own personal journey with that. And obviously we're not giving therapeutic advice, but it is research shows that a combination of both is extremely effective. Dr. Goodman, is there a comparison in terms of efficacy with medication, the pharmacology in depression versus efficacy of pharmacology with OCD? And is there a better response with one than the other? I mean, obviously everybody is individualized and has different experiences.
That's a really good question. And you tend to ask me questions that no one knows the answer to make me look bad, but it's okay, Ethan. But I'm gonna have to think from my own experience, because I don't think there's any answer in the literature, published literature. I've seen some cases, I can think of many cases where they had comorbid depression and OCD. I prescribed an SSRI, and the depression got better, but the OCD didn't. So you sometimes see that. So and that may still help, because then they may be, as they're less depressed, they may be able to adhere more to behavioral treatments. But in terms of overall response rate, I would think that depression probably responds better overall than OCD, because you've got a heavy lift. When you're prescribing an SSRI for somebody who has OCD and depression, you got two targets. You're trying to help the depression, but you're also trying to improve the OCD. And just in general, OCD is more resistant to medication, particularly after if you're somebody who's never had the medication, the chances are, it's a good chance it may help the first trial. But if you've been somebody who've had several different trials of SSRIs, subsequent trials may not be as effective for either the depression or the OCD.
Thank you, Dr. Goodman. Alexandra, do you mind sharing maybe what your secret sauce has been for you, what works for you? I know it's a weird term to use for this. Sorry.
No, I think that's a good term. Oops. Sorry about that. I just unplugged myself. There we go. So yeah, I think my secret sauce has definitely been a combination, which speaks to what Dr. Franklin and Dr. Goodman have both said, as well as you, Ethan. My depression was really so bad, and honestly, my OCD so severe that my head was never quiet, ever. And it was always either alternating between OCD and depression. So when I got on a medication that actually worked for me, it was like someone took a fog and lifted it right out of my brain and actually made my brain quiet so that I could use the tools I had. And it was like a light switch. It was almost immediate when it worked for me. It worked, and all of a sudden, all this therapy that I'd been going to for years, I was able to utilize it. And it was like I got a whole new outlook on life. And I know that sounds really cheesy, but it was really life-changing for me. And I'd been very resistant to the idea of medication because, you know, I think a lot of us, we don't want to take something every day for the rest of our lives. That's a scary thought. But for me, it helped.
And I have the same experience. You know, I've been on a combination of both. Well, obviously I was on meds before I even found treatment, but the combination of both is what really worked for me and continues to work for me. And, you know, I can tell you that early on when I was at the bottom and just finding help and so significantly sick and depressed, you know, they did add some medications for my depression specifically to help that lift so I could really engage in ERP and ACT and other modalities of treatment, since of which I've gotten off those specific medications because for me, depression was a symptom of my OCD. And so once the OCD got better, the depression lifted. So I totally agree with Alexandra and have a very similar path in terms of my own journey. So thank you for that. Somebody's question here. Somebody actually, we can post this. 7:11 p.m. Kathleen wrote, "Can PTSD cause OCD?"
Can PTSD cause OCD? That's a really interesting question. And, you know, I think a lot of the time with these comorbidities, we do want to go back to what Dr. Goodman said previously. We want to know if there's any indication on the patient side as to which one came first. But most of the time when we're seeing PTSD, most of the time I would have to say that OCD precedes that. So if we understand how PTSD works, there has to be an activating event in order to have that diagnosis manifest. What I want to distinguish, though, is can OCD be stressful? Can it feel like trauma in a person's life? I think that is definitely a question worth exploring and looking at in therapy. And to that, I would say yes. I think the effect, the impact of OCD on a person's life can be a type of trauma. But I would say that the diagnosis of PTSD would be something a little different.
But I was going to ask you, Dr. Goodman, isn't there research to show that if there's predisposition to OCD, that PTSD can, or not, the trauma itself can activate that?
I think that's a fair hypothesis. I've certainly seen many cases of what you might term post-traumatic OCD. It's not extremely common, but you know, I've seen some people where there's a particular event that they trace their OCD back to. But usually I dig a little bit deeper, and if you dig a little bit deeper, you find that the substrate was already there, and maybe there was a traumatic event, but it was more. It helped precipitate it, but as you said, you know, they already had the predisposition to develop OCD.
I think what we do see very frequently is that OCD explodes. If there's a traumatic event, then a person's OCD and trauma will be so tightly interwoven, and the OCD will be much more chronic and unremitting following a trauma. And the treatment of comorbid OCD and PTSD is a really interesting thing. And there's a lot of overlap with the symptoms, but in the treatment of it, really important and difficult to, at some extent, tease them apart.
Thank you, Dean. Appreciate that. Alexandra, did you have anything to add on that?
Yeah, I mean, I have PTSD along with my OCD and depression diagnoses, so I get all the letters behind my name and none of the education. But I like that.
I'm totally using that.
Thanks. I thought it was pretty good. But I would say that, yes, like Dr. Franklin said, there's a lot of overlap in between the symptoms, and there is a lot of I think you can get stuck with OCD and trying to tease those out. And it's almost more important to just focus on the evidence-based treatment and the modalities to kind of ground yourself and just work on both at the same time. I do feel that my OCD became worse after my traumatic events, and that it almost kind of like my life hit this weird earth-shattering wall. Like it was kind of like something inside of me broke, because there's something about that PTSD that ruins your executive functioning, and it's already compromised with OCD. So it's like you just revert back to lizard brain all the time, and it's so quick to go there. It's so quick. It's like you just lose your footing.
Absolutely. I think for me, it gets to a point where I think initial diagnoses are important for treatment, and understanding what the protocol is. But I talk to so many people that start with literally listing everything that they have or been diagnosed for. My response is always, at a certain point, the diagnosis becomes irrelevant, because our goal is the same. We want to live a full life. We want to live a meaningful, full life. What do I have to do to get there? So if a diagnosis is important for that, and that helps me get there, then great. But if it doesn't, if it's just more things that I need to add on, what do I need to do? I don't care. So I don't want to be defined so much as a label, simply of, I want to live a full, meaningful life. And so, direct me on that path. If those of you watching, we're going to do some Q&A now. And then we'll continue to have, obviously, meaningful conversation around that. So feel free to ask some questions in the comment thread. This isn't a question, but I'm gonna turn this statement anyway to Dr. Goodman, because he's sort of on the forefront of new modalities of treatment. So Don Calvert wrote, who's an avid watcher of the live streams. This is at 7:18 p.m. Fran, if you want to post it. I just wish we had newer treatments for OCD and depression. I've been on so many, including magnetic stimulation and ketamine. They barely touch my symptoms. I also have a lot of trauma. I wonder how we can find treatment that quiets the mind, lifts the mood without making us feel medicated. That's sort of the golden egg for, I hear you.
There haven't been any medications developed specifically for OCD in decades. I hate to say that. Now there is some hope on the horizon, in that there is I'm not going to mention the name of the company because it'll sound like a plug, but there is a company that seems to care about OCD, and they have a compound that seems promising. Not a standalone compound, but what we call as an adjunct or an add-on medication to the SSRIs, and they've gone ahead, and they're in the process now doing a very large, multi-center, multinational study to see if they can prove that this new compound, when added to an SSRI, is better than adding placebo. There's a little bit of hope on the horizon. There is interest in different neurotransmitter systems. I probably do a little bit less work in pharmacology than I used to. More of my work these days has been on the use of devices, and most of the patients I treat are the most severe treatment-resistant patients. And in those cases, we are using deep brain stimulation, which is a neurosurgical procedure, which, by the way, and I won't get into in detail on that, but it's in talking about the relationship between depression and OCD, when DBS works, and when I see it work, it's always the depression that lifts first. And I've never seen a case where we were using deep brain stimulation where OCD got better first. If you don't see improvement in mood, and sometimes it's almost immediate, the OCD is probably not going to get better. So it's a very, very interesting relationship. We not only see it with medications, but we see it with devices.
You love hard questions, Dr. Goodman, especially when I ask them. I don't know if this is hard or not. You'll have to tell me. But I am curious. Are we going
to throw me a softball? But my daughter plays softball. She won't let me.
No, but I think Alexandra may be able to speak to this. We may have brought this up in other live streams. I know we have, but part of the issue with medications for those of us that suffer is that at a certain point we feel like a lab rat and a guinea pig, because it's all guessing and trial and error. Yeah. So it's like, here's this med, we're going to go up, we're not sure, we're going to go down. Oh wait, no, it doesn't work. Let's try something else. And I'm like, and we understand that it is trial and error. It is a collaboration, and we have to reframe it. Do you think there's a future where we can have more targeted pharmacology?
Oh yeah, I think that's where we're headed. And even in the work that I've been doing lately in deep brain stimulation, the goal is not to expand to widespread use of neurosurgery for OCD. It's really to learn more about the circuits. And so I really see OCD as a circuit-based disorder, and that kind of fits with kind of metaphors we were using earlier about, there being a part of your brain that's taking control and knows what's important to you and what you fear the most. I think that can be explained by looking at the circuitry, and hopefully along the way we'll identify some nodes in those circuits that could be the targets of new medications.
Thank you, Dr. Goodman. Eric has a question at 7:19 p.m. It's a brand new time. I just invented it. And I'm going to throw this to Dee. How can you tell the difference between intrusive thoughts and ruminating? Or is there a difference? Is one more automatic and the other more conscious?
Yes, I noticed that question quite a while ago. I thought it was a very interesting one. I think on the one hand, it maybe doesn't make too much sense to differentiate them. But I will say that there's something interesting about rumination. And I want to use a cooking reference because it just tends to work so well. Ruminating thoughts, you can think of like a marinade, like a stew. This is when you're very much in your head, and it's kind of like a low valency or low energy thinking and thinking and thinking onto something. A lot of times my patients, when they describe ruminating, they're describing that place of being kind of out of it and distracted with your thoughts, whereas patients tend to prefer to describe intrusive thoughts as being a much more impactful train of thought. From a clinical side, I personally see them as very much in the same thing, and I would treat them similarly with the CBT approach. I don't know if you guys agree with that.
Alexandra, I always go ahead, Dr. Goodman.
Yeah, no, I completely agree with it. I'm sometimes a bit petty about these different definitions. That's just me. But
yeah.
So I generally use the word ruminating outside of OCD, and I think you are too. Although you can get people who ruminate, say, with generalized anxiety disorder. I see that more as worrying, about things that are realistic. But excessive, worried about, their family's health, their finances, their job security, those kinds of things. I tend to use the word ruminating more in that context. Other people don't agree with me, and that's fine. They may think of ruminating more in terms of depression, that they're focusing more on past events, and I agree with that. Whatever word we use to describe that. In depression, people tend to be thinking a lot about regrets, things that they should have done differently, replaying that. Now, you can get a little bit of OCD, a little bit of that in OCD, but in OCD, it's different. It's much more focused, and it's a dynamic process, as we all know. That the OCD is generating new concerns all the time, and it's evolving. It's not, and whereas it tends to be in depression, it's the same things over and over again. In OCD, it's more inventive.
I sometimes think Rodin's sculpture, The Thinker, everyone knows this guy, right? The Thinker is the perfect way to describe rumination. And if you picture that sculpture in your mind, you can almost imagine what it feels like to be in Rumination City, taking a detour and being stuck there for many, many minutes.
Well, I like you're describing it as a marinade. The etymology of the word ruminate comes from ruminants, which cows. So cows have extra stomachs. So that's how they digest all that fiber, and just sits there and stews in all these juices.
That's a great way.
Yeah.
Alexandra, what are you thinking?
Yeah, you're good. So yeah, I was thinking, I've always felt like ruminating for me is much more active. So it is this very active process that I am engaged in. And when I am doing it, I can lose time so easily. It could be like an hour, and I think it's been 2 minutes, and I will get locked in that stare, that thinker stare. And it's when it's OCD, it's almost like I'm actively trying to figure out a problem that has absolutely no answer. It's actually kind of like I'm studying psychology because there's just more and more questions and no answers, which can actually lead me to become depressed, because what'll happen is the OCD ruminating will get me so hopeless about the fact that there's no answers to my questions that then I start to fall into that depressive state And the more existential kind of those ruminations get, the worse the depression gets, versus my intrusive thoughts, which my intrusive thoughts are generally just like a one-off, like a quick, bad thought, or a sticky thought that I can more actively engage from, versus rumination, where I think I'm thinking normally, and then I fall down that slippery slope of ruminating, if that makes sense.
Yeah, I totally agree with you, Alexandra. For me, like the intrusive thought is the leaf flowing down the river, and then I have a choice whether to engage it or not. And if I decide to ruminate on that thought, then that's a compulsion for me. Otherwise,
Agreed.
thought just passes by, and I can have multiple intrusive thoughts, but I still don't see that as rumination if I'm not giving them focus and they're not affecting my behavior. They're just like fireworks in my brain and they're annoying, but I can still carry them with me, as opposed to directly engaging with them. And then for me, that's what becomes rumination.
Ethan, if I could just jump in here and make a plug for the importance of emotion, the role of emotion and mood in this part of the discussion we're having. I think it's important to point out the reciprocal function between thoughts and emotions. And I really like what you were saying, Alexandra, because as you become more ruminative or you're having more of those sticky thoughts, your depression can get worse. And it's really tough because the more that the emotions kind of rise, or the more that the depression rises, I think the more sticky the thoughts get. And so you have this reciprocal vicious circle going around. And then to bring it back to what we were talking about earlier, if you see the mood changing, then that really impacts behavioral components. So there's a whole system at play here where you see thoughts, emotions, and behaviors being linked. And when something brings the whole system down, it's really difficult to stop that cycle, really hard. I don't know what you guys have found to be effective. How do you make it stop?
Ethan, do you have a thought?
I have lots of thoughts, but I was going to turn to you, Alexandra.
Well, it's totally up to you. Usually when I get stuck like that and I notice that my mood is starting to get low, and I think that this is easier the further along in your therapy you are, I will try to mindfully disengage from the rumination and then go do something that I really love. It's got to be something I really, really love, or it's not going to work. So depending on my energy level and how my mood is, that may be play a video game, put on a funny show, go do some exercise, or if I'm really, really bad off, I will turn to one of my friends. Depending on how I'm feeling, it might be a peer that has OCD who understands what I'm going through, or it could be one of my close friends who distracts me. But anything to just kind of break that cycle and give me hope. It has to be something that gives me hope and makes me feel good and smile. Otherwise, it's not going to work.
So then the question becomes, and I'm going to be a devil's advocate. Also, if you have questions, put them in the comment thread. Lots of great conversation, lots of people opening up, which I love. But if you have a question, put a question mark. I tend to scan question marks. And yeah, so there's your secret. But I will get to other ones. Alexandra, I love that. But I could always make the argument when I was struggling. It's like, well, I couldn't find hope. I was hopeless. Didn't matter what I thought of. Didn't matter how I had no feeling. All the things that I loved before, all the things that turned me on, no longer turn me on, no longer excite me, no longer stimulate me. And so therefore, how do I get better? Those were the kind of things that I was constantly asking. And I just happened to be at first at the clinic that Dee works at. Although she was not there at the time, I didn't have the pleasure of seeing me cry on the floor every day for months on end. But with that, I've always viewed thoughts and emotions as sort of like a wrestling tag team, where like the thoughts come in and they tag in the emotion, and the emotion jumps in and is going to further convince you that the thought is real because now it feels a certain way, right? And then it's our job to tease that apart. So I think there's like a couple modalities of treatment we can look at that's really effective from like the lived experience point of view. I think what Alexandra is talking about obviously is like living into values and opposite action, which is just basically getting into something that's meaningful. We don't want to get tied into whether it's avoidance. If it's value driven and we're doing it and we're still experiencing thoughts and feelings, that's a good thing. It doesn't mean we're going to feel better. But, there's also the idea of just being able to sit with it and experience it for what it is and not judge it, and which is a more sort of acceptance commitment therapy approach to it, and sort of just make room for it and let it be there, and being okay not being okay, and being comfortable not comfortable, and then getting involved in focusing on your values and things like that. So I agree that the emotion and the thoughts are so intertwined, and the emotion really just adds a punctuation on the thoughts. To think it is one thing, to feel it is like, oh, well, everybody says I need to trust my gut, and my gut feeling is saying, oh, this must be real. I must want to jump. I must want to touch this. I must want it because I feel it. And I think, which is why I learned early on is that we can't trust feelings in treatment. Feelings are valid, not invalidating feelings. Simply saying we can't use feelings as a barometer for success in treatment.
Right. I completely agree with that.
Danny asks, at 7:22 p.m., is having more than one psychiatric illness common with OCD? Dr. Goodman?
Well, we already mentioned one, which is depression. So it is certainly common to have OCD and depression. When I start seeing 3 psychiatric diagnoses or 4, I'm thinking it's probably overdiagnosed. I just, I'll give you another example. One of the areas I've had a long-standing interest in is a relationship between OCD and Tourette syndrome. And if you're familiar with the relationship between Tourette's and OCD, a number of patients with Tourette's develop obsessive compulsive symptoms. And my experience in treating OCD and Tourette's is they come in with 2 different diagnoses. They have Tourette's and OCD, but the form of tic-related OCD seems like a different entity to me. It's a form of OCD. It's certainly related to a tic or a Tourette syndrome, but I think it's a single diagnosis. So although they may get 2 diagnoses, they may get a diagnosis for Tourette's and they get a diagnosis for OCD, I think it's one underlying brain-related disorder that manifests in both the presentation of tics as well as OCD symptoms. So we have to be a little bit careful about these multiple diagnoses. I think that depression, OCD, that's an important one. You want to have both because, as we discussed earlier, you may take different treatment approaches if you have somebody who has both OCD and depression. You may have to address the depressive symptoms straight on and not just work on the OCD, or do them concurrently, as Dee was suggesting.
Dear Alexandra, any thoughts?
I have a question for Dr. Goodman, if that's okay.
You have to get in line. There's lots of people that have questions, Alexandra.
But I'm on the panel. So you were talking about the link, kind of, or the concurrence with Tourette's. And so for some of us with OCD, I know that we say we have tics, right? Like I have a certain phrase that when I'm very stressed, I absolutely must say when I'm getting into the shower. And it is a completely nonsensical, ridiculous thing. And I have no control over it. I also have tapping and things like that. So how do we tease out what's OCD and what's Tourette's, and which diagnosis does it fall under?
Yeah, no, it's a great question. I'm not going to try to answer your question directly because I would need more information. But in general, if I have somebody coming to me, I'm trying to decide whether they have both diagnoses, or like as I put together, I think it's a single diagnosis that manifests in 2 different domains. I would look at their developmental history is very important. Generally speaking, the tics start earlier than the OCD. It's not universal, but generally you see tics start between the ages of 7 and 11 years old. And, they usually start as simple motor tics, the most common ones being eye blinking and other facial tics. So there's a kind of a natural anatomical progression of tics over the lifespan. And usually I look for that. But you're right. I mean, the other thing that we've observed is patients that do have both OCD and tics, or tic-related OCD, if you prefer, their OCD symptoms sometimes does include things like touching, tapping, repeating, or need for symmetry or exactness, or more just so kinds of rituals. They may not be worried about transmitting a disease or being responsible for somebody getting sick or injured. It may be that they have to do it until it feels just right. And that begins to sound more tic-like. So, but I'm not sure that the distinction is important, though, because when we get down to the treatment, we're probably going to treat them with very similar tools.
Thank you.
Did you have any thoughts on that?
You know, in the spirit of what you're saying, Dr. Goodman, I have similar theories about feeding and eating disorders and OCD, where you're describing how tics and OCD kind of overlap. From my experience treating eating disorders for a very, very long time, I see a tremendous overlap with OCD to the point that I believe at a brain basis, it's pretty much the same condition that we're looking at.
We have a ton of amazing, thank you, Dee. We have a ton of amazing questions, so I'm going to move a little faster through this. Also, in regards to various illnesses, I've always described my own, because I have a variety, I describe it as a combo meal. I kind of like to picture the school in elementary school, like the main dish is OCD, but I have 4 sides, you know, so that's kind of like how I've always pictured my own diagnoses. So anyway, with that in mind, Danny F asks, actually Jessica has a quick question at 7:25 p.m. Sometimes when my depression is bad, OCD almost takes a back seat, like my mind can't be bothered to give attention to my thoughts, compulsions. I almost feel like, what is the point? Is this typical? Dee?
But if, okay, there I was going to ask for it to appear.
Yeah, for sure. Sorry about that.
So when the depression is bad, the OCD takes a back seat. You know, I think that this is totally possible. I think that we've all experienced this to some extent in our personal lives, whether we have or have not got OCD. It makes complete sense that when the mood is so low, it's hard to think about many other things other than the things that you're ruminating on in your depression. So I think that your hypothesis makes a lot of sense. And maybe as your mood begins to lift, then your brain has space to think about the OCD related things. So we always kind of think about how free is the mind. If the mind is really bogged down by sadness and depression, it's not very free, perhaps, in your experience to think about worry, to ruminate, to perseverate. So yeah, I think that your point is a good one. I'm sure many, many people could identify with that.
Ethan, can you tell I want to ask a question or answer?
Very much so, but I was going to let you just chime in.
So there's one from Jessica Ivy here from 655. Can we pull that one up?
Oh, yeah. Did I miss one?
I don't know.
Fran, do you have it? I can't.
Well, I'll read it. Dr. Goodman, would you say that SSRIs are helpful with Tourettic OCD? That's another term. I've not had any luck. And
sorry, Dr. Goodman. 6:55 your time. I was like,
okay, got it. Okay.
So Fran, 7:55 p.m. Jessica Ivy. Yeah, Dr. Goodman, would you say SSRIs are helpful?
Okay, so this shows how old I am. So back in the 90s, I saw my first case of somebody who presented to me as a young adult. He was in the early 20s, presenting with OCD, but he clearly had a history of Tourette's. And so I tried him on an SSRI. It didn't help. It didn't help with the tics. It didn't help with the OCD. And then, it was even back then, we knew that one of the medications that help suppress tics are the antipsychotics, the dopamine antagonists. So I added a low dose of an antipsychotic, and I expected it would help his tics, but I hoped it would help his OCD. And sure enough, it did. It helped both his tics and his OCD. And then that led, to some grants and papers later, and here we are now. Kind of the second line pharmacological treatment for people who have failed SSRIs is a consideration of a low dose antipsychotic, in particular in patients who have a lifetime history of comorbid tic disorder. That's pretty much held up pretty well over time. It's not a guarantee that it's going to work, but if you have, what I find is if I have somebody who has not responded to several trials of SSRIs, and they also have a clear history of chronic tic disorder or Tourette's, I will discuss with them adding a low dose of an antipsychotic, and it may help with both their tics and their OCD.
Thank you, Dr. Goodman. 7:27 p.m. Danny F. asks, how can you deal with medicine OCD? anytime I try medicine, I think I'm going to have a bad reaction. We'll start with D, and then I'm going to get Alexandra's thoughts on this as well.
So medicine OCD, Danny, I want to just clarify that you're talking about worrying about the effects of the medication.
That's probably what he's talking about.
I would imagine so, right? Yeah. I mean, I think that if you look at what Danny's saying here, that's an intrusive thought, right? There's something to worry about, something that's really stressful for him at the moment. So, you know, the worry is the enemy in this case. The targeting that intrusive thought is really what we want to look at, and not get too preoccupied with the medicine itself. So how to deal with it? Well, Danny, I would generally, when someone presents with this kind of problem, I would recommend that they stop fact checking on Google, stop checking the medication bottles, stop as many checking behaviors as you can do, and follow the advice of your medical team.
Yeah.
Right? That's the best way to deal with it, because the more that you engage and the more you get hooked into those worry thoughts, the higher the risk is that you're going to get sucked into that OCD cycle.
I think that's great advice. The only thing I would add is I'm more concerned if I'm prescribing a medication, I'm more concerned about tolerance and reducing the unpleasant side effects. And it's going to take time anyway. I mean, I think all of us know that the medications, whether we're treating depression or OCD, particularly OCD, we're not going to see results for 4 to 8 weeks and sometimes longer. And although there's a long time to wait, it's really important that the patient feel that they can tolerate the medication. So I generally start at very low doses. Well, I wind up in a higher dose than I might use in depression. I start at a low dose and really work with the patient to make sure they can tolerate it. And often, and the reason for changing from one SSRI to another may be because of side effects, not because of effectiveness. So if it really looks like somebody is not tolerating the medication, your worst fears come true, you try the medication, it really doesn't agree with you, a different medication may be much better tolerated. And it's hard we sometimes do genetic testing, but they're not foolproof. So it's a bit of a trial and error.
Absolutely. Alexandra, I have thoughts on this subject. Alexandra, I'll let you weigh in first.
Yeah, I mean, I can definitely speak to this. I still sometimes get very scared when I have to take a new medication. It doesn't necessarily have to be an SSRI. It can be anything. I start getting those kinds of fears, and I think it's more the uncertainty of taking something new and putting it in my body that is frightening to me, because I feel like I am going to lose control over what's happening to me because I just ingested something. And for me, what really is helpful is just kind of disengaging from that and accepting the uncertainty. So just kind of saying, well, maybe not. I could have a reaction. I could get sick. Maybe not. And just sit with that and just use it as an opportunity to practice my acceptance and my ERP. And that's really it. It's just sometimes we have to accept that uncertainty, I think, and that's hard for us when we have OCD. It's hard to do anything where we don't know the outcome. We always want to know the outcome.
I love that, Alexandra. And you said it best. At the end of the day, this symptom or subtype is no different than any other, and the treatment is working with a clinician, doing ARP, embracing uncertainty. It's all of those modalities of treatment that are most effective. And I actually want to get on to more questions, so I'll save my stories for another time. Also, everyone is asking so many great questions. If for some reason we don't get to your question, we'll be giving out an email address at the end, and we can give it to any of the wonderful people on this panel who will happily respond, and we'll get your answer to you. So we'll keep going as quickly as we can until 8:30, but please know that we will get you an answer if we aren't able to. Giovanna at 7:27 p.m. asks, what do you want to do? What do you do when you don't respond to any medications, including ketamine, and the anxiety is so great you can't do ERP therapy? I also tried theta burst EMS. So I'll start Dr. Goodman off with this.
This is a tough one. So let me see what well, I don't know what any medications means, but I'm going to assume that means multiple SSRIs and clomipramine, because and ketamine, anxiety is so great you can't do ERP therapy in 30 days. Well, I mean, it's not ideal to use benzodiazepines with ERP. I mean, there are lots of theoretical reasons why, if you take a drug like alprazolam or Xanax or clonazepam, Klonopin, that you may not get the full benefit of ERP, because it's going to reduce your anxiety response and prove to yourself that you can manage the anxiety without the aid of a medication. That said, as long as it's not long-term, there are occasions where I will prescribe, at least as needed, PRN, benzodiazepines in cases like what you described, where the anxiety is just so great that stands in the way of making progress with other modalities of treatment. That I just would try not to use them. We'd have to decide whether it's going to be on a PRN or regular basis. But I'd be interested in the ERP therapist's point of view on that.
Oh, thank you. So, never mind. D, he was talking about you.
Yeah, I completely agree. In severe cases, it's absolutely necessary to have a benzo to allow the person to at least get started. But inevitably, down the line, we're going to recommend tapering off the benzos, because it does interfere with the efficacy of any exposure therapy that we have to do.
It's also not good for you. I've been on benzos for 25 years. I'm willing to talk about it. I was prescribed it when it was still an in treatment, and no psychiatrist decided to take me off it. And now my body is so addicted to it. Every time I try to titrate, I get really sick, even in small doses. So I'm still trying to figure out going down. It took me 2 years to go down to 0.5 milligram. Not because of what it was treating to begin with, just because my brain doesn't know what to do without the crutch. And so I would experience all kinds of weird side effects. Not to scare anyone. I'm just saying that don't stay on it long. Google calls me and asks me for any recent side effects because they just have no data for somebody that's on a benzo this long. It's a terrible joke, but it's true. With that in mind, let me just add to this particular conversation, which is, my specific case, when I really struggled with engaging in ERP because of how dysregulated I would get so significantly dysregulated that I would just be a puddle on the floor, not exaggerating at all. And I couldn't even remotely engage in ERP just because I was so dysregulated. And pretty much from what I described, very much seemed like a 4-year-old, throwing a tantrums, crying, screaming, so forth. And I agree with Dr. Goodman in some cases, obviously benzos are very effective, dialing that. Also, I want to throw out dialectical behavioral therapy because I think DBT is really effective in emotional regulation. Many times individuals with OCD who are trying to engage in ERP but just can turn to DBT first and really gain some mindfulness, some grounding skills and tools to really help them curb their emotional responses to these triggers before then engaging in ERP. I mean, do you have any additional thoughts on DBT? But I found it extremely helpful, and I've heard it's extremely helpful with other individuals that I spoke to.
Definitely. The distress tolerance skills, interpersonal effectiveness, I think it's an integral part of really getting well. And I would say also that, earlier on in the town hall, we were talking about spiraling or going back to discover the value. And I think that technique is embraced by DBT as well, really going back and having a look at the chains of behavior and the cycles of emotion that really get you from something that's important to a really bad situation. So I agree with you, Ethan. I think that DBT is a wonderful intervention alongside a traditional CBT and ERP.
And Giovanna, you don't need to post this, Fran, but Giovanna adds, I feel hopeless because I've tried every depression, anxiety, OCD medication, including off-label, but nothing works for me. It's been ever since I was pregnant in 2010, 2011. Before that, I responded to medication. I am struggling and open to anything. What I would suggest, Giovanna, and if anybody else is, you've obviously put a lot of time and effort into medication. And I would just be curious if you had any experience or have dove into cognitive behavioral therapy at all, because in both of your questions, you talk about medication and those type of treatments, but haven't talked about treatment and therapy. And so, exposure response prevention, acceptance commitment therapy, dialectical behavioral therapy, as we talked about. There are a variety of therapies and exposure therapies specifically that are research has shown can be extremely effective and especially in concert with medication, if there's something you can tolerate. So I would just encourage you to maybe explore. There's tons of resources on the IOCDF website regarding various modalities of treatment, the ones that I've just described and you've heard here today. So I encourage you to look at those. Let's see here. Felice Baker asks, at 7:32 p.m. Fram, is OCD so resistant to medication? Is it really a serotonin issue? Oh, reading. Apparently, I need a medication to help me read. Dr. Goodman, if OCD is so resistant to medication, is it really a serotonin issue?
All right. So I try not to make this too long an answer, but again, when I started, it was actually in the 80s. I hid that from the audience earlier. I actually started in the 1980s on this, and at that time, the prevailing biological hypothesis was that OCD was a serotonin disorder. Why do we think that? Because evidence was beginning to accumulate that it was only the serotonin reuptake inhibitors were effective in OCD. I spent many years and published many negative studies trying to find direct evidence of a disturbance in the serotonin function in patients with OCD. And I gave up on that, and so is most of the field. So how do we explain the fact that the serotonin reuptake inhibitors are preferentially effective, whereas other antidepressants don't seem to be effective? Well, I think the best answer I can give is that it doesn't mean that there's a disturbance in the serotonin system in OCD. What it may mean is that when you give a serotonergic medication, you may enhance the serotonergic system, and that may compensate for a disturbance somewhere else, and something where another circuit of the brain that's coupled to it. But there isn't any direct evidence at this point that there is a imbalance of serotonin in the brains of people with OCD. On the other hand, there's very, very powerful evidence that the best chances of a medication working is if you pick one that affects the serotonin system.
Thank you, Dr. Goodman. I see some other questions. This is a perfect question for Alexandra. Tracy asks at 7:33 p.m., can OCD come out due to stressful life events?
Yeah, definitely. So I tend to find that my OCD, I call it like a flare. My OCD flares up whenever I have a stressful life event. And my OCD got really bad when I was initially stressed out. So important things like my mother having surgery, me learning to drive, any kind of important developmental milestone, I can look back and remember that there was OCD involved and flaring up. The birth of my son, my OCD got so incredibly loud, it was ridiculous. So I think OCD targets those times almost, and it latches on to whatever we are so stressed out about or whatever is so incredibly important to us. And it can have lasting ripple effects. My mother's surgery caused me to be afraid of driving because I had to drive back and forth to the hospital. And so it will latch on to something that seems random and just continue after the stressful event is gone.
That's an excellent point. And you're absolutely right. Good stress and bad stress, right? It's very frustrating when it impacts the good stuff, because you're like, good things are happening. Why is it attacking me now? But I actually invite it, because when OCD starts attacking something that's really good, I know that it's really good. I'm like, oh, good. That's something really cool that's happening, because otherwise OCD wouldn't care. So
isn't that reassurance seeking?
No. Anyway, moving on. Danny at 7:33 p.m. asks, can OCD and borderline personality disorder feed off of each other?
Yes, what a wonderful question. And just on the heels of us talking about dialectical behavioral therapy. So yes, Danny, I think that this is a wonderful question here. If we put two conditions together that really experience that high emotional intensity with frequency, with unpredictability, it would be OCD and borderline personality disorder. So if you look at just the idea of one having a reversive experience to one's own emotions, and then we describe that reciprocal function that thoughts and emotions have with one another, you can only imagine how a borderline personality disorder, or any personality disorder for that matter, could really exacerbate OCD. You see, personality disorders are disorders of emotion dysregulation at their core. So OCD and intrusive thoughts are really fueled by that emotional intensity, that dysregulation. So yes, that is a very long-winded response to your question, but the short answer is yes, I think that you're onto something there.
Perfect. Nicole at 7:34 p.m. asks, can emetophobia be an early manifestation of OCD? I'll throw that out to the group.
Yeah, I see a lot of emetophobia at NBI Ranch. And also over the years, treating eating disorders. This is a really common one. And for those of you who are not sure, emetophobia is a fear of vomiting, and it does function like any other phobia, like a fear of spiders or a fear of heights. So to answer the question directly, yes, I think any phobia is part of the broad anxiety spectrum and OCD spectrum. But it is, to be exact, it is a phobia. Treatment-wise, we don't treat OCD and phobias differently. So when you're thinking about the possibility of having both a phobia as well as OCD, you would treat it the same way.
Thank you. Thank you. William at 7:35 p.m. This is, I'm debating whether to have Dr. Goodman. Do you want to answer this, or I'm debating also? Maybe, it's at 6:35 p.m. your time. I don't want to get too bogged down, but his obviously the question is valid. I was just debating whether I should email you or not. Let me go ahead and ask it. Everybody's now curious. So William asks, are any panelists aware of any studies exploring combined treatment, ERP plus SSRI, for individuals diagnosed with OCD and MDD? I ask because I reviewed meta-analyses for combined ERP plus SSRI versus monotherapy ERP for OCD in isolation in my review piece linked below, and surprisingly discovered no benefit for combined versus monotherapy. I'm wondering if the research findings, if there are any, are different for OCD plus MDD, or if this is based primarily on clinical experience, which is what I was going to say.
Yeah, that's what I would say. Yeah, I mean, I haven't looked at that literature specifically, but I'm not sure if they break it down by OCD with and without comorbid depression. It might be in there. I might be missing it. And the other thing too is that my clinical experience doesn't completely match up with some of the published literature. I mean, as we mentioned earlier, I do think there are some patients who benefit from the combination of ERP and medications, even though some of the studies show that the combination is no better than ERP alone. I think you have to take that was in a controlled trial, but in real life, there are definitely patients who will benefit from the combination more than one modality alone.
Mm.
Thank you, Dr. Goodman. Appreciate it. Incidentally, for those of you, if I happen to be skipping any questions, it is not on purpose. So please, 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 forgive me. Don't send me angry emails, although I will respond and apologize. Also, we will give an email address at the end, and feel free to ask the question, and we will make sure to get it to these amazing people. There's some great questions here still. Real quickly, though, we always have to be sure to define what we're talking about. I'll throw this at, I don't know, Dr. Goodman, 7:39 p.m. Susan asked, deep brain stimulation?
That was the question. Yes, deep brain stimulation, DBS. Yes, this is not for everybody.
What is it exactly?
It's a neurosurgical procedure. So I work some of my current research involves working with neurosurgeons, and and it's the same, a very similar approach is used for treatment-resistant Parkinson's disease, in which there are actually electrodes implanted in the brain, connected to a device that's under the skin that I can program, or the neurologist can program if it's Parkinson's. And it produces direct stimulation of an area of the brain that we think may be involved in OCD. And this is only for patients who have failed a long list of medications, ERP, very severe OCD, and have had it for a number of years. But in about 2/3 of those cases, DBS does work where everything else has failed. And the very interesting observation, we've built this in what we built into our study. You may like to hear this, Ethan. Is we made sure that in addition to the DBS, even though they've all had ERP in the past, we then give them another 2 months of ERP. And every single patient that we've done that with said that really made the big difference. So they might have shown improvement with the DBS alone, but when we added in the ERP, this round, they had further gains from the ERP than they had the first time.
That's awesome. I love that. Danny, I see your question. Please feel free to email it to me. I know we already answered one of your questions. I do want to get to Stacy's question, but there is an answer, Danny. There's hope, and email me that question because it's a great question, and I definitely have some. And Alexandra, I'm sure we can both weigh in on it. With that, Stacy Black at 7:39 p.m. Alexandra, I'll throw this to you first. Curious to know if Ethan or Alexandra experienced any noticeable emotional blunting from SSRI meds.
Yeah, that's a good question. So I was on SSRI meds first. I think I took several. I took Paxil, that's an SSRI, and I was on fluoxetine and several others. And I did notice what I would call an emotional numbness. It wasn't anything too terrible, and it was certainly preferable to being completely depressed, but I didn't notice enough benefit really to continue on it. And I think that may have been because I wasn't with the right therapist, to be honest. I should have been having ERP too. I eventually landed on an NRI, and that has actually been really wonderful for me. And I don't have any kind of emotional blunting. In fact, emotional blunting for me is now a sign that I'm getting depressed.
And to answer your question, I had a very similar experience. I've been on the gamut of SSRIs, I've been on SRNIs, I've been on antipsychotics and mood stabilizers through the various journey of the last, I guess, 17 years before landing on treatment and therapy. And I did experience it to some extent in some places. I would tell you that the current cocktail, quote unquote, that I've been on for the last 10 years, I don't experience emotional blunting. I cry when I need to cry, I laugh when I need to laugh. And I think, and this kind of goes back to the question earlier about sort of the fear of medication and getting on medication. It's very interesting because I think I found issue with every medication I was on when I was first treated with medication alone. From the age of 14 on, I couldn't go up to a certain amount. I would feel weird. I would feel uncomfortable. I feel like foggy. I feel like a ghost, shell of my former self. All of these things. What's interesting is when I got extremely sick to the point where I was just completely unable to function, and was put in a psychiatric hospital. I mean, they start you at the highest dose. There's no titrating. They go, here's 300 milligrams of this, here's 300 milligrams of that. Number one, that absolutely quickly cured me of my fear of like what happens if I take this medication, because they were starting on the highest dose. But it also kind of taught me, it's like, maybe I can tolerate some of this stuff, and maybe I'm just scared of what it means or how it affects or how my OCD perceives it, or any psychosomatic symptoms that I'm, maybe manifesting on my own. I remember when I was there, I was put on an Afrinil, which is a mipramine, and I think within 2 or 3 days, I noticed an insane decrease in my OCD symptoms and the thoughts. The other problem, though, was I was completely unable to pee. And so needless to say, the doctor took me off, which was devastating because I remember sitting there and saying, I don't need to pee. Like, just give me this medication. I'll figure it out. Because I was so miserable with the thoughts. I was like, I can work. I'll figure so I won't drink water. Just make these thoughts go away. But needless to say, I think that we have to weigh. So many people hear, oh, I want to be creative, or I don't want to be hindered, or, I don't want to be my own personality. And unfortunately, it can get to a place where you're just not functioning at all. You barely or don't even exist. And when that becomes the issue, frankly, I didn't care whether I was funny, whether I was a personality. I just wanted to live again. And so whatever that meant, I was willing to try. And I would just encourage you not to have to get to that place in your own journey, where maybe you're willing to feel a little discomfort. Maybe you're willing to feel some emotional bluntness or change in personality at first. Because I will tell you, every time there's been a point of breakthrough where I've sort of got back to baseline. and it's happened every time. And that's just my own experience. But I would say, like, it's a collaboration, as Dr. Goodman said, between you, your therapist, and psychiatrist. Keep it a collaboration, but be open-minded, because the more willing you are to embrace that uncertainty and lean into it, the better results you'll find. In my opinion, I don't know, Alexandra, you're nodding.
Yeah, no, I mean, I agree with everything you said. And I think it's so important for us to be able to collaborate. And I think in my story, that's why it's so important. When I got a good therapist, I was able to do these things and get on these medications and actually see a benefit. And I don't know that it was so much a difference in the medication. I might be able to revisit one of those old meds and be okay on it. I think it was more I was getting in my own way because of the OCD, because I was so afraid of all these things. What does it mean to be on medication? What if the medication hurts me? Like, what if the medication makes me not me? What if the medication makes me not creative? And so I think we assign all these things to the medication, and it actually stops us from getting the benefit of it when we might be able to. And so, yeah, I would say if it's something you're considering, be open to it and lean into that uncertainty, just like Ethan said.
Dr. Goodman, as the resident medicine expert here, any thoughts on that subject?
Just I agree with everything that's been said.
Excellent. I'll stick with that. I'll take that, and so will Alexandra. We'll send you an invoice. Anyway, and unfortunately, this is our last question. At 7:40 p.m., Paolo asks, "Hi, currently ruminating severely. Do you have any advice what to do? Just done lots of cleaning, then now ruminating. So frustrating. Hope you can give me some advice what to do at this moment. Thanks." Dee, I'll turn to you first.
Yeah, Paolo, I saw your question there a little while ago, and I hope that the minutes that have passed by have eased for you. But I will say that the first thing that you can do right now is to stop, listen to the advice and the wisdom of the people on this call, and if you can, allow yourself to unhook from the thoughts that are driving this rumination that you're in. Listen to what Alexandra said. Go and do something meaningful for yourself. Go and do something that's enjoyable. Go and connect with someone that means something for you. And there's distraction as a technique shouldn't be the only tool in your basket, but it definitely is an effective one to use sometimes when the rumination is really bad. I don't know how much therapy that you've done in the past, but if you're able to do what Ethan was suggesting as well, it was an excellent suggestion. Let that frustration, let the sadness, let the worries, let them be there without engaging in them. And that's kind of the best advice that I could give with the limited information I have about Paolo.
Thank you, Dee. Any thoughts, Dr. Goodman?
No, I think it's great advice.
Alexandra, what would you do in that situation?
I mean, it's hard to say without knowing exactly what's going on or what the exact symptoms are. But, when I find myself ruminating late in the evening, it tends to be more of an existential thing. And if I'm too tired to go do something, or if I know it's close to bedtime, sometimes I'll take a journal or a piece of paper, and I will allow myself to feel those feelings and sit with those thoughts and then write them down. And I make sure at the end to counter each and every thought in writing. And I think that's kind of a CBT skill. And when I write down what I'm countering, I may not believe it at that moment, but I leave that paper lighter. And sometimes I even rip it up at the end. And it just kind of helps to get myself back in a more positive frame of mind.
Thank you, Alexandra. Okay, stay on. Everyone stay on. So first of all, I want to thank Dr. Goodman, Dee, and Alexandra for this amazing conversation. So thank you all so much for joining us. This has been a great one, and there's so many fantastic questions here. So the first thing I'm going to do, and Hiro, I see your question as well. Hopefully you're still on. For those of you that have questions, I usually don't give out this email, but I'm going to this time. So first of all, if you have questions that weren't directly answered, email them to justethan@iocdf.org. It's my email address. I answer it directly, and I will make sure that the questions either get answered by myself, or if you want them answered by Dr. Goodman or Dee or Alexandra, just note that in the email, and we'll make sure to get that to them. I'll give you another email address as well, but we'll hit this with a double layer here. Just as always, like to preface, please give me a moment to answer all the emails. I get a number of emails, so give me a moment. Don't bash me too hard, and we will get you. We will get you answers. So just wanted to give that out quickly. Some really cool things coming up. But first, I want to thank the IOCDF, and actually, this particular presentation was presented in partnership with the Anxiety and Depression Association of America, the ADAA. And for more resources, you can visit the ADAA.org. And of course, thank you to the IOCDF.org. You can visit the IOCDF.org at IOCDF.org. Now, I know I'm good like that. Redundancy is key here. Also, I always want to thank Fran behind the scenes for manning the comment thread and putting up the questions and just doing all this magnificent digital voodoo. I have some big announcements. Don't go anywhere. Next week is a diversity roundtable, as well as our anxiety and athletes town hall. You can visit IOCDF.org/peace of mind for all of the upcoming virtual program. 2 more announcements. Don't go. First of all, registration is open for the 1 Million Steps for OCD walk. 36 walks are happening around the country in person as of right now. Local rules may apply, including our flagship Boston walk, which will be held on September 18th. So you want to find a walk near you and register. It's free. Did I mention it's free? It's free. They usually have swag, drinks. It's a good time. You'll meet some cool folks. Go to IOCDF.org/walk. Not done. One more big announcement. Registration is open for the OCD online conference. The national conference is taking place October 8th through the 10th. It is an online conference, hence the online OCD conference. Learn more, register at IOCDF.org/conference. If you haven't already, you want to be notified about all the programming the IOCDF is having over the next month, definitely be sure to subscribe and follow on Facebook and YouTube, as well as Twitch. Where's the face land? Oh, just between. Sometimes we get the face on a guest, and it looks really entertaining. Alexandra, if you want to stand up, we might experience. There you go. That's perfect. Okay, thank you. With that, finally, if you have questions, additional questions, whether they're for our panelists or just in general, never hesitate to email the IOCDF at info@iocdf.org. With that, thank you so much for spending your Thursday evening with us. We really appreciate it. As always, I like to point out that you yourselves were amazing advocates today, being open, talking about your own personal experiences and supporting one another. So thank you so much for that. So until next time, stay safe, stay vigilant, feel the feels. Don't let OCD off the hook. And we'll talk to you next time. Have a good night.
Thank you so much, Ethan.
Thank you, Dr. Goodman.
Thanks, guys.